Okay, so um, we'll go through as much as I can, but we'll sort of stop at a sensible point rather than start a kind of another topic and then not finish it off. Um, I really struggled with Strab until an unspecified moment where things just sort of clicked. And the reason is I find, firstly, the most annoying thing about it is there's basically about 100 ways to say the same thing. And they're always put across as completely separate diagnoses when actually you're talking about the same thing, depending on who it is that you're talking to. A lot of the conditions overlap. You can either be talking about exotropias or you can talk about A patterns, and actually you're basically talking about the same thing. And that can sometimes take a while for you to actually clock that you're doing. And because there's loads of ways of categorizing something, depending on what you're reading, you're going to be reading Strab in a completely different way, and it will feel like you're reading new material all the time. And so until I literally started doing Pede Strab as a rotation, and actually having someone to just sort of go, what the hell does this actually mean? You then start to clock that a lot of it is actually the same thing. Um, and I do think there is an element of it that can be simplified, but there are parts of it that are quite complicated that I will probably purposely avoid. So I am not a Strab surgeon. I'm nowhere near one. So please try to sort of also put things by a strabologist. But the point of this is to try to sort of give it to you how I understood it. And if that works, then it works. And if it doesn't, then sorry. So the way I thought about it, and like I said, this is probably wrong, but I sort of think of things in a sort of the horizontal issues, the vertical issues, and then all the other stuff, in terms of like your syndromes, your lesions, your nerve palsies, and all of that sort of jazz. We're not going to go into that stuff too much. We're going to sort of talk about the more basic horizontal and vertical issues. I think for most people, when it comes to nerve palsies and syndromes, they're actually not that bad at it. And that's usually because it kind of came up semi in medical school. So you've kind of come across it multiple times and it's a bit easier to understand. It's more the sort of childhood ESOs, exos that I think people don't necessarily know that well, and can sometimes take a while to sort of settle in. So we're going to talk about the more obvious and high yield stuff, in terms of exam and also just in terms of your day to day. And then for the really specific things, again, I will open this up to see whether or not, questions mainly on how does this stuff get examined, for the FRC opt. But for the more specific stuff, I would sort of recommend you actually go to someone who knows what they're talking about. So for the horizontals, it's basically ESOs and exos. Your eyes are either pointing inwards or they're pointing outwards, and then that could be for any number of reasons. Um, the terms that I think are worth knowing. So again, some of this might be stuff that you guys already know. So sorry if I'm talking to you like idiots, but competent versus incompetent. Competent is basically you've got the same angle of squint no matter what direction you're looking at, and incompetent is it changes. So incompetent squints are usually your things like your nerve pauses and stuff like that, whereas your basic ESOs, exos in childhood tend to be a bit more competent. Your sort of convergence to accommodation ratio is an important thing to understand. So when you're accommodating, simply by accommodating when looking to your near, your eyes are supposed to converge, and you will either do too much of that or too little or the right amount. And that can then present as either exos or ESOs, depending on what the problem is, because actually a high ACA ratio can give you an exo and it can give you an ESO. So the point of that is not to sort of remember it as high ACA ratio means this. It's just understand what it is, when understanding how the different um, alignment, misalignment kind of stuff presents. I personally felt gazes was the easiest way to discuss things and present things for the exam. I think when people start talking about abduction, adduction, I only use those terms when I'm very obviously got a palsy in front of me or some sort of like Duane's, for example. Whereas otherwise, I would literally just say, in up gaze, in right gaze, in down gaze, and in left gaze, what do the eyes look like? So in right gaze, there's limited adduction, so I wouldn't say sort of, Dexiver like levo version. I felt like those terms are unnecessarily complicated, and they also try to make you sound like you know what you're talking about. I think it's a waste of time. Just talk about gazes. Um, I think it's the easiest way not to get mixed up with different terms. So, esotropias, an inward turning eye. In my mind, the way I split these up, and you'll actually find there are some textbooks that follow this as well. So you've got the primary esotropias and then the secondary esotropias. So your primary esotropias are usually the stuff that you're going to see in childhood, and your secondary esotropias, even though you may see them in childhood, they just have a different etiology. And I think that etiology is useful when deciding what it is that you're looking at. Um, so with infantile esotropia, so these are your primary esotropias. Anything infantile is basically something that's present in the first 6 months of life. And there are certain characteristics to infantile esotropia. And these are worth knowing. So your infantile ESOs are your kids who are either born that way or people within the first few weeks start to notice it. It's usually a big ESO, so at least sort of like 30 diopters. They are otherwise usually neurologically normal. So that's the reason that that's there is that's quite different to exos. So when you've got an infantile exo, that's usually a bit more sort of red flaggy than an infantile ESO because infantile exos are more commonly associated with neurological issues. So infantile ESOs are more typically neurologically normal. These guys do have a high risk of amblyopia, especially when things are fixed. DVD and inferior oblique overaction is associated with infantile ESO. They usually come in with a latent nystagmus, and you're usually treating these. The idea behind what is causing an infantile ESO are basically medial recti that are too strong. So either you're going to relax both of them, or you might want to do a unilateral recess resector depending on what the overall problem is. But these are your sort of these are worth knowing, these characteristics of infantile ESO, because again, high yield and really easy to come up in your OSCE in terms of like quick questions of how you would kind of differentiate between an infantile ESO and something else. But this is very typical of your infantile ESO. A quick point on what DVD and inferior oblique overaction are. So dissociated vertical deviation, there's a few things that are associated with this. Infantile ESO is probably the most useful one to know about. And it essentially means that when the other eye is fixating, your eye drifts upwards. So the way you sort of check this is with a cover on cover. If you cover one eye and the other eye is fixing on a sub on an object, the eye behind the cover will sort of drift upwards. Usually they kind of grow out of that. But in extreme um, cases, you can sort of operate to try and fix that. And then your inferior oblique overaction, this is just over elevation of the eye and adduction, again, associated with an infantile ESO, where when the eye is actually adducted, it also comes up slightly. And these are very typical characteristics of an infantile ESO. Now, when it comes to your accommodative esotropias, so your infantile ESO is within the first 6 months. Accommodative ESO tends to present later in childhood. And I don't mean like 8 or 9, I mean just in the first couple of years. And you can either think of them as associated with a high refractive error or they're independent of the refractive error. So remember, an accommodative ESO is essentially your eye moving inwards related to the accommodation of the eye. Um, and that can either be in the context of it being refractive, i.e., the patient usually has a high refractive error, they're usually quite high hypermetropes, or they're non-refractive in that the esotropia is completely independent of the refractive error. So if you're looking at your refractive accommodative esotropias, so this is either kind of fully refractive. So basically, it's completely to do with the hypermetropia. As soon as you correct the hypermetropia, the esotropia completely resolves. Fantastic. That's all you need to do. You fix them with glasses. End of discussion. Your partial accommodative, your partially refractives are give them their refractive correction. Some of their angle gets better, but it's not completely resolved. And then you can always do the rest with surgery. So that's where the partial refractive kind of comes in. Your non-refractive are sort of two main reasons or a mix of both. So the non-refractive, if you think about what your hypermetropes have to accommodate much more than myopes. Yeah. So what happens is they accommodate loads and then they also converge loads with each unit of accommodation, if you sort of think of it like that. So they will end up when they're trying to look at their near, they have a convergence excess, and then they will converge way too much for when they're trying to accommodate. So they end up with an esotropia. So that's what we call a high accommodation, your ACA ratio. And you can fix these guys with bifocals. You give them sort of a near ad, and then they don't need to accommodate so much for when they're looking in the close when they're looking close by, so they don't converge so much, so their esotropia is fixed. But then you also have an issue with accommodation weakness. So basically, they're hypermetropes, or they're low hypermetropes, so they can't accommodate as well as the usual eye. So then what the eye does to try and compensate is they converge too much, essentially, but they're not actually accommodating, if you see what I mean. So these people are not being able to see, so it's just their eyes are trying to converge. It's a similar sort of thing, but they're not actually accommodating. So it's not accommodation convergence. It's just convergence. Or you've got a mixed picture. And again, these are people that you can look at with surgical correction. So those are your sort of childhood ESOs. Those are the two sort of main ones that I think are worth knowing. You do then have your other sort of fancy ones, but I think for secondary causes, the point of this is essentially being able to discuss differentials for esotropia when you're speaking to somebody. And in childhood, you've got your primary esotropias like infantile or accommodative, and then you've got secondary esotropias. And then your classes you're thinking about are neurological, things like a sixth nerve palsy, myogenic causes like myasthenia gravis, restrictive causes like thyroid eye disease, orbital fractures. And then you mustn't remember that you mustn't forget your sort of post-operative or your consecutive causes. So for people who've had previous lateral rectus strengthening procedures for an ESO and then the lateral rectus slips, you'll end up with an ESO again. That usually you can sort of tell someone has a slip because they pretty much have absolutely no function in the direction of that muscle. Or you've had an overcorrection of an exo. And sensory is less common in that what I mean by that is usually a sensory misalignment tends to be an exo rather than an ESO, but you can have a sensory esotropia. So these are the sort of secondary causes of esotropia. So we've sort of talked about now inward turning of the eye and what can cause it. And then we'll sort of now go on to sort of your outward turning of the eye. Um, so the way I think about this is you've got your constant infantile exotropias. You've then got causes of intermittent exotropias. And then, like I said, the other sort of causes that similar to what we discussed the last time. Now, with exotropia, infantile exotropia, like I said, is sometimes a bit more concerning than infantile esotropias. And that's usually because, again, they come with a large angle. Again, they can come with DVD. But with these children, actually, they can quite frequently come in with neurological abnormalities. Or because you're more likely to get an exo with a sensory issue, you also need to consider that the eye may actually have quite serious pathology. So patients with, for example, cataracts, patients with retinoblastoma, patients with severe ocular pathology, essentially causing blindness or amblyopia, they end up with this infantile exo. And because things like cataract or retinoblastoma is a possible cause, you need to make sure that you're considering those things when you're looking at an infantile exo. So just in terms of safety and in terms of bearing things in mind, when you have a child with exotropia, especially the very young ones, you do really need to consider A, neurological abnormalities, and B, whether or not you're looking at a secondary exo because of a sensory issue in terms of the ocular exam. So you do want to make sure you get a really good eye exam for these kids. Then you've got to go intermittent exotropias. So the intermittent exotropias, so I probably should have put basic first. So that's your most obvious one. Your angle of exotropia is the same when the child is looking at the distance and also when they're looking at the near. So it doesn't change. And what we mean by intermittent is that it can come and go. It's not always a constant exotropia. So they don't always have that angle there. They don't always have the exo there. And obviously, if they're intermittent and it comes and goes, and they can and they can show you that they have both BSV and good vision in both eyes, you're not really going to intervene. It's more the ones that have an amblyopic risk that you're worried about. But your basic exotropias are essentially that. So you're looking at the angle is the same for both distance and near. Your distance excess exotropias are essentially where it's in the name. Your angle of deviation is bigger when the child is looking at the distance. Now, if you think about it, that makes sense because when the child is looking at the near, they are converging. So usually your angle is going to be bigger when they're looking at the distance. Now, they can either have a simulated distance excess or a true distance excess. And this is where it's useful just knowing about the cover test, where for someone who looks like they have an exotropia that is larger in the distance, what you're going to do is you either sort of quote unquote blind the eye with a +3 lens, or you cover it for about 30 to 60 minutes, and that dissociates the two eyes. And then what happens is a sort of, it depends on the textbook you read, if you want a positive result for that test. Essentially, what you're looking for is that the angle for the distance reduces. So it becomes more like the near angle. And I think a positive test is it's meant to sort of almost halve in terms of your angle for distance, but I wouldn't quote me on that. But the point of it is what you're trying to understand is that these are patients that have a high accommodative convergence ratio. So again, when they're looking at their near, their eye comes in, and then we're looking at for the distance when they're not accommodating, the eye looks like they're further out. But then when you dissociate the two eyes, that angle sort of comes closer again. The true distance excess is basically after this test, the angle doesn't change and the distance still remains much bigger than the near. And that's how you sort of compare between the two. Convergence insufficiency, if you think about it, is another cause of exotropia. Their eyes are going to be on convergence, they're not going to be converging as much as possible. So again, as logic would have it, that's more a problem when they are meant to be converging. So when they're looking in the near vision, their deviation is going to be greater because it's more of a problem with their convergence than it is with anything else. Now, the way you think about ESOs is it's more of a problem with strong MRs, and the way you think about your exos is it's more of a problem with strong LRs. So the way you're going to sort of intervene with these things is usually looking at your lateral rectus, or again, if you have an amblyopic eye, you may want to just only operate on that one eye. And to be honest with you, with your operations, there's lots of different ways of doing the same operation. There's your sort of first choice stuff for your horizontal misalignments, and it sort of changes depending on things like previous surgery, health of the eyes, um, and those sort of kind of basic surgical considerations. Um, all right, so that's mainly your horizontal ESOs and exos. Now, I've not spoken about nerve palsies on purpose. I think those things, like I said, they sort of probably belong in a sort of tutorial of their own. And I also do think they tend to be better understood by your general ophthalmologist, because they're related to other things, and we sort of know what the six muscles do. But I think this sort of chapter of ESOs and exos is less understood. It certainly was for me. Um, I was going to say until recently, but I wouldn't even claim to actually know it now. But so this is why I focused on this. We can do another session on nerve palsies, and I intend to. But the point is that I think these are the ones that are sort of less understood. And I think for the part two oral, again, you're going to sort of you'll be shown a video of it like a child with eye movements, and it's more likely to be this sort of stuff that comes up with the children in the videos. With the adults, you might be a bit lucky and you might get a sort of basic nerve palsy. So then we've got your vertical stuff. Now, for your vertical deviations, there's the two main ones that I would sort of consider that again are not palsies or syndromes or sort of lesions in the head, which I will go to later. But um, you've either got your sort of monocular elevation deficit. This is kind of related to your double elevation deficit, if you've seen that sort of thing in oculoplastics. But essentially, you've either got a tight inferior rectus or a hyperplastic superior rectus. So you basically also just can't lift the eye. And if they also have a ptosis and they can't lift their lid either, then you're also thinking double elevator palsy. Brown syndrome is, again, annoyingly just another eponymous name that you need to remember, but this is an issue with your superior oblique. So when you're thinking you've got a mechanical restriction of the superior oblique, Brown syndrome can either be congenital, i.e., it can either be they can just be born with a problem with a superior oblique, or it can be iatrogenic. So with the iatrogenic causes, it's either sort of previous surgery, trauma through the lid, especially through like the sort of superior orbit. Those things can all cause Brown syndrome, but Brown syndrome is a mechanical issue. So um, your congenital causes will be a mechanical sort of restriction of the superior oblique, where you can go in and either you sort of put a spacer in and you can break things up and you can try and get the superior oblique moving again. Or for the iatrogenic causes include, like I said, things like buckles, for example, can give you a sort of iatrogenic Browns, or it can be secondary to things like trauma. Then you've got this sort of combined group of syndromes. Now, this name, congenital cranial disinnervation syndromes, I wouldn't necessarily remember it as that. This is just a useful way to sort of categorize these other things that people have heard about. And essentially, it's just a collection of disorders that can give rise to lots of different strabismic pathologies. And actually, from my understanding, there's lots of things that used to be sort of seen completely in isolation that are now sort of seen as all grouped and all being brought under this umbrella of essentially a disinnervation, where you've got either a hyperplastic nucleus or some sort of aberrant innervation. It's just an issue with how your muscles are being innervated. So your most typical versions of this are things like Duane's, which again tends to be better understood because people talk about it a lot, but I will talk about that. Möbius syndrome is another example of this, where you've got a hyperplastic sixth and seventh, and sometimes even the fifth, eighth, and 12th are involved. Möbius syndrome is what you're thinking about. You're in an SBA, you're going to talk about people with like who can't make any sort of facial emotions, for example, and things like that. Congenital fibrosis of the extraocular muscles. Again, you've got a hyperplastic superior third nerve. So again, these are patients who they have a bit of a ptosis, they can't move their eye upwards, and you're usually seeing a genetic component to that as well. So it tends to run in the family, and even your Marcus Gunn jaw winking is a sort of version of this, where you've got aberrant innervation between the fifth and the third. So you're uh, of the trigeminal, and essentially whenever you're sort of talking or eating, you'll then get the closure of the eye because of the superior third. So this is all these are all grouped under this understanding of disinnervation syndromes. The reason I think it's worth thinking of them like this is when it comes to your exam, the way you're sort of going to not trip over yourself is by not immediately going down the diagnostic route and by not immediately naming an issue. The more classifications you have in your head that you sort of understand, the easier it is, I think, to kind of crawl things out of the back of your head in terms of that library of information. So when you're thinking of, causes of problems with the sixth nerve, for example, or problems of things, you can talk about, disinnervation syndromes, and then that immediately then helps you remember things like Duane's, things like Möbius. So I think it is worth having these categorizations because with strabismus, what's really easy to end up doing is you just remember these random diagnoses all over the place and you never know when to bring them forward. So I think by splitting things up into ESOs, exos, vertical problems, it becomes much easier for you to sound like you have a differential sieve in your head rather than you're just spouting random diagnoses at the examiner. So a bit on Duane's. Again, so this is basically a hyperplastic sixth. So your lateral rectus, which is usually innervated by your sixth nerve, is now instead innervated by your third, which you can immediately see why that's problematic. Two muscles that are doing completely the opposite thing are trying to be innervated at the same time. You've got two different types of classification. Don't ask me what the second one was. I can't remember. But the Huber's classification is the one, two, and three. I think A, B, and C is the other one. And there's a mild difference. But the point is that the easiest way to remember this, which I'm sure you've heard before, is the number of Ds in the word. So type 1 has one D, so it's limited abduction of the eye. Type 2 is limited adduction, so two Ds, and then type 3 is your three Ds. Oh, I should have made that a capital. I need to go back and sort that out. Type 3 limited abduction and adduction of the eye. And for this, how you can treat Duane's. Now, remember, I know I've said surgery here, but whenever you're in the exam, you're going to go conservative medical surgical. There's not a lot of medical treatment for things with strabismus, but essentially conservatively, you're always going to say Does the patient have a problem with it? Can it be fixed with prisms? And if not, you then go down the surgery route. Now, when it comes to the surgery, what you definitely want to try and avoid doing is strengthening the lateral rectus that has the problem. Because if you think about it, you're basically making the problem worse. So you want to try and avoid the lateral rectus um, on the, so that should say ipsilateral again, not unilateral. So you should avoid the ipsilateral lateral rectus for the issues with Duane's because you're going to strengthen the problematic muscle. So don't do that. But that's a bit on Duane's. Now, alphabet patterns. Again, this is basically just another way to confuse you. These are not separate pathologies. This is just a way to understand how to treat. Yeah. But if you want to, and if it works better for you, then this might be another way of categorizing the different types of ESOs and the different types of exos. The reason I don't like it is a V pattern can be an ESO issue or an exo issue. And it's the same with an A pattern. But the point of it is just to understand where the deviation is worst. So if you do have an alphabet pattern where the deviation changes depending on up or down gaze, you're then going to alter your surgery slightly. So for V patterns, for example, if it's an esotropia, that means it's worse on down gaze. And if it's an exotropia, it's worse on up gaze. You just think of the shape of the V. So this is things like inferior oblique overaction, Brown's, superior oblique underaction, or superior rectus underaction. And then your A patterns are the opposite. So your ESO is worse on up gaze and your EXO is down worse on down gaze. And inferior oblique underaction, superior oblique overaction, and IR, UA are sort of uh, ways of differentiating this. Now, where this is useful is if you think about, for example, inferior oblique underaction and Brown's, they can sort of present in similar ways because Brown's is almost like a bad superior oblique, whereas inferior oblique underaction is sort of the same thing. So the eyes, oh, hold on a minute. Have I confused myself again? How awkward. Yeah, no. So yeah, so your Browns is a if you're comparing Browns, which is superior oblique underaction essentially, because it's a restricted superior oblique, um, you're going to get the V pattern because you're when you're trying to look so superior oblique is essentially going to help you with down gaze. So when you're trying to go look downwards, you're going to get you're restricted essentially. So your inferior oblique, you end up with an inferior oblique overaction as a result of all of that. So it ends up being very similar. There are ways of differentiating between Brown's and inferior oblique. A lot of that is to do with either etiology of the patient, but also things to do with the angle of the deviation. So we can talk about that another time. The point of alphabet patterns is to consider where you're going to move your recti. So you just remember the acronym male, and then you're going to move your medial recti to the apex and your lateral recti to the ends, and that's the apex of the point. So if you have a V pattern, your medial recti are going to move down, and your lateral recti are going to move up, depending on what you're moving around. That's basically it. Um, I didn't want to sort of talk about too much because I think Strab is hard to digest. So um we can maybe touch on other topics in Strab or maybe do this again at some point if people want. But if you don't mind, please do fill out the feedback. Um, I can send a link across as well, but just scan that. That's very, very helpful to me.